name is Lloyd Smith. I'm head of APMA's ACO task force, and I wanted to welcome everybody tonight to this call, the title of which is the Accountable Care Organizations, How to Position Yourself to Compete. I want to also just make note of the fact that if people are involved in ACOs actively at this point, or they think they will be, APMA would appreciate hearing from you either at our main number or through online contact, so that we can gather as much information as we possibly can from you. We're also looking for anybody who's interested in volunteering as a liaison between your state or your ACO and APMA. Included on tonight's call is Dr. Melvin Price, who is the Chief of Medicine and Surgery and Subspecialties for Manatee County Rural Health Services. He's going to present. And also Sarah Swank, who's a lawyer for Oberkaler and a principal in the firm's health law group, and co-founder of the Oberkaler Healthcare General Counsel Institute. She has a long CV, and I think it's, at this point, it's important for us to note that she's certainly qualified to present and is going to give us a good talk that you'll hear later on. In order to avoid taking any additional time, I want to hand this right over to Dr. Price so that he can go forward with his presentation.
Sure. Thank you very much, Sam. Again, as noted, I'm the Chief of Medicine, Surgery and Subspecialty Care for Manatee County Rural Health Services. We are a federally qualified health center. I've been with Manatee County Rural Health for about 10 to 11 years. We have 27 sites spread out over 3 counties. Last year, we were awarded ACO status, and I currently serve on the ACO board of our particular ACO called All Care Options. I've been asked to talk a little bit about, what do the specialists need to do or need to show. From my standpoint, and serving on the board and serving with Manatee County Rural Health Services, specialists are going to be somewhat limited based on specialty. The specialist will need to show, absolutely will need to show through your EMR or any other data collection that you can gather. You need to show evidence-based outcomes with cost containment, because that's what the ACO really is, what they're looking for. They're looking for quality care with being able to decrease the cost. And if you look at the 3 major cost centers for an ACO, the 3 ones that they really want to control are hospitalization, pharmaceuticals, and specialists. That's where the majority of the money will go to. So we have to be able to fit into this model, because this will be the model for the future. We currently have 4 podiatric physicians in our group, and as the ACO grows, obviously we're going to have to include other specialists and other podiatric physicians to cover an expanded area. Again, those specialists need to respond quickly. If, for example, we have a patient in the hospital on a Friday and you don't see that patient till Sunday, that's not a good thing for the ACO, because that basically increases the length of stay. Again, driving up costs. You must be able to, again, show your data. You don't necessarily want to increase your cost per patient. Typically what happens is people want to maximize the cost per patient. You don't want to necessarily do this in an ACO model, because, again, you're driving up the cost. That's not what the ACO is looking for. They don't want someone who's churning. From a podiatric medicine standpoint, person comes in with an ingrown toenail, you don't necessarily have to take an x-ray every time they come in for that ingrown toenail. If the outcome's going to be the same, why increase the cost for the x-ray? Unless there's a valid reason for you to take that particular x-ray. But that's just one example of driving up costs when you have the same outcome in two different situations. We'll also need to look at where do you go, from my standpoint and from my point of view, the biggest bang for the buck to be able to get into an ACO is diabetic foot care. And this is, I believe this to be true because we have 10,000 baby boomers entering the Medicare market every day. Each diabetic ulcer is going to account for $30,000 in cost, as we all know. We can reduce that cost. We can keep that patient out of the hospital. We can keep that patient out of the emergency room. Those are the talking points that you really want to drive home to the ACO, because if they can decrease, again, that hospitalization and that ER cost, and you can help in that, that's going to increase their margin in shared savings. And a lot of people worry about the fact that, well, I don't want to be the diabetic doctor and do the diabetic ulcers. Well, you know, diabetics also sprain ankles, they break ankles, they participate in sports. You can still treat and deliver all the facets of care, including surgery. Diabetics do everything that everyone else does. They just happen to be diabetic. But if you're talking about getting your foot in the door, what you need to show is I can reduce cost, give quality care, keep your patients healthy, out of the emergency room and out of the hospital. The best way to do that is through diabetic foot care. We also need to be included in this model because, again, it will be the model for the future. You need to look at innovative ideas and look at different methods to deliver patient care. One particular method that we have in place at Manatee County Rural Health Services, and which I will be utilizing in the future, will be telemedicine. This is going to grow in the future. You'll be able to reach more patients at a reduced cost. We already have an outlying site. We can utilize that telemedicine to have that patient come into a quote-unquote virtual room. I can see my patients here in the office, and I will get on my schedule. Telemedicine patient will be my fourth patient. Well, as I move to my computer, I can get back. I can actually see that patient 50, 60, 70 miles away. I can evaluate that patient, give the nurse instructions on what to do, and if in fact that patient then needs to come see me, then we'll do that. But again, being able to reach that patient, keep them out of the emergency room, evaluate through telemedicine, I think if you can come up and utilize this particular technology, it will definitely serve you well in the future. One thing that our COO was looking at and he's very interested in the future is going to be e-visits. And I know this sounds a little bit out of the box, but there are companies and pretty large insurance companies that are moving throughout the country to set up e-visits. This hasn't gone down to the specialists yet, but going to the primary care physicians. But we need to be knowledgeable about it. We need to be able to converse and possibly participate once these things become widespread. Yeah, lastly, we should really ask if you're going to participate in the ACO with your contractual negotiations, if we meet those benchmarks to help improve the quality of care, reduce the cost, we should participate in that percentage of cost savings. I know in our ACO there's been talk about putting 10% aside for specialty care to be distributed to those specialists that can demonstrate efficiency, effectiveness, along with cost savings. With that, I can push it over to Ms. Sarah Swank.
Great,
Sarah.
thank you. I think that really laid the foundation for what I'm going to walk us through, and I actually want to retitle my slides now, getting your foot in the door with ACOs, because I think that's a great title for a presentation for you all.
Sarah, can I just interject one thing? One thing I forgot to mention to the group is that time for questions at the end. And if you would please type your question in the box located on the webinar tool, then we can hopefully address some of them at the very end if we have time. Go ahead, Sarah.
Great.
Sorry to interrupt.
Oh gosh, no, great. Yeah, please type your questions as we're speaking. You can put them in there, and we'll take them at the end. And so let's get started. So why was 2012 so important of a year? And I put a picture here of our lovely Supreme Court. What I think was interesting is I had clients that were in all stages of either denial or aggressively moving forward or in a wait-and-see pattern. And one of the big things that they're waiting to see was whether the Affordable Care Act was going to be overturned in part or overturned completely by the Supreme Court. Then we had the election, and I think, again, another wait-and-see moment. But just to give you, I think sometimes it's good to hear a little bit of legal background and political background to get us to understand sort of where we're going. And the whole concept of ACOs, or Affordable Accountable Care Organizations, they started as actually a demonstration project. And they were pretty integrated systems that were participating in the demonstration. And actually, several of them declined once the regulations came out to participate. They said that the quality measures were too high, and when the proposed regs came out, they actually said that this looks a little too onerous. The Affordable Care Act actually has a provision in there for the establishment of an ACO program. It also has an establishment of a bundled payment program, which is not fully launched, but we'll talk about it a little bit later when we talk about what other options are out there. And then the CMS Innovation Center. So they put a lot of, we can say CMS put a lot of eggs, and Obama did, into in the basket on the ACO program. Because of that, when the proposed rules came out and they didn't meet with the fanfare that everyone was expecting, they actually came out with a Pioneer ACO program in the interim, and that was through the CMS Innovation Center. So when you hear Pioneer ACO, they use the term ACO, which can cause things to be really confusing, but it is actually a separate program that doesn't have any regulations. It's actually done without regulations, but with guidelines. And so, and then the final rule came out, and if you look in the commentary to the regulation, they use the word flexibility, and they use it so often you can almost create a drinking game out of every time you see the word flexibility. They really wanted to show that they wanted participation. And they also came out with an ACO Advanced Payment Initiative, which was to address some of the concerns that you would need a hospital or a big health system to fund the infrastructure needed to launch an ACO, and that if CMS was really saying this could be done at a small level, it could be a small group of physicians that might not have the same buying power that a large integrated health system would have, then they needed to do something about that. And that's the advanced payment model. And I actually have physician clients who have ACOs in that model and are receiving upfront payments to help build their ACO. The other thing that's historic about this ACOs is that I've listed here all the regulatory agencies that had to get together, including the IRS, the DOJ, CMS, OIG, and the FTC. But what's interesting about that is they all came out with a statement and their guidance at the same time. And that's the first time, I think, in the history that that's happened. In fact, I heard that a lot of the leaders were actually called to the White House to make sure that this would happen. Because this is a historic change. You're not only changing the way care is delivered and the way payments are delivered, but the way that independent providers are going to interact with each other. And that's got implications from the IRS for tax-exempt hospitals, and it's got antitrust issues, which we'll talk about in a moment. So what is an ACO? The definition and the regulations, I find it's not as helpful. So I think breaking it down into its parts is helpful, just to give a framework. It's a voluntary program. It means putting in an application and entering into agreement with CMS. So it's not a required element. You have to have at least 5,000 eligible beneficiaries. So this is for Medicare. You'll hear the word ACO thrown around. There are things such as commercial ACOs and other ACOs, but the true ACO program is a Medicare-focused program. You have to have a tax ID number, which is very easy to get. You need to set up some kind of legal entity. You need to be able to share savings and losses, and then there's quality measures. And what you'll get is the whole premise of this is this idea that you've got your fee-for-service world, and then you're laying on top of it a quality payment. And you'll see this movement happening in other areas where pay for performance is becoming the norm. So let's walk through who's eligible to participate. Now these are actually set, except for the two that are at the bottom that say new on this slide. These are actually set by statute. So Congress decided who could actually form an ACO. Now this doesn't mean other people and entities can be members of an ACO or work with an ACO, but these are the individuals and groups that can form them. So we have professionals in a group. We've got networks of individual practices or practices getting together. We've got partnerships and joint ventures between hospitals and professionals. We've got hospitals that employ professionals and critical access hospitals. And what you can see here is you don't actually have to have a hospital to form an ACO. And I've formed ACOs that have hospitals, but I've also formed ACOs where the physicians have gotten together in that market and have formed an ACO on their own and have purposely excluded the hospital. So there really is no one-size-fits-all. What's interesting to note is that in the proposed rule, federally qualified health centers and rural health centers were added. CMS does have the right to include other entities in this, but they haven't done anything more than the two so far. And one of the reasons why that they were worried about adding qualified health centers and rural health centers was their ability to capture and report data. And so they have to go through a little bit more hoops during the application process to prove that they're able to do that. So what I think that speaks volumes of is how important data is to ACOs and how important, even outside of the context of this program, data will be in the future. And you start thinking, well, why does CMS need all this data? I would argue that it looks like to me that they're moving towards a potential capitated model again, or maybe we'll still keep the bifurcated system of the fee-for-service and the quality layer on top of it, quality payment layer. But it does seem like this data capturing is important, not just to give good quality data, but the government wants this data as well. So, oops, sorry, our slides are getting ahead of us. So is there a place for us? So is there a place for you? And and how does that look? And how do you get involved? And I speak about this a lot, and because I feel rather passionate about it. I came out of Trinity Health and ran the legal department of one of the hospitals in the Metro DC area, and saw what the big systems were doing, but also got to see what was happening locally and sort of that contrast and see what's happening across the country. And one of the things that, I was worried about was it's having the big systems, but also worrying about the idea of having, for those who want to continue having independent practices. And how would that work? And is there a way to partner where you don't have to go into an employed model, or would you want to go into an employed model? So one of the things is to be what I call this idea of ownership. Ownership can align with who's an ACO participant, who can form them, but they also, there's going to be some restrictions we'll go into about how does that look from a governance perspective, and how do you get a place on the board, and what does that look like? Obviously, if you're employed by a hospital system, then that will that can be in itself its own ACO, although the clients I have that are hospital systems that have employed physicians are really wanting to reach out not only to primary care physicians in the area, but also specialists. Primary care physicians will drive what beneficiaries are in the ACO, but specialists, I think, will have an important role as well. When you look at the concept of, right now the government's really focused on fraud, but there is also this concept of waste, which might not be fraud and might be considered medically necessary. And I think the idea of the MRI is the perfect one. I mean, if you go into the hospital, you have an MRI done, and then you go back to your primary care doctor and they don't like your MRI, or your specialist doesn't like your MRI, and there's multiple MRIs being done, at what point is that considered waste? And of course, I don't think that's for lawyers to decide. I think that's for clinicians to decide. I think that's one of the things that's so exciting about ACOs and kind of where we're headed. It's supposed to be very physician-led, and it's supposed to be based on good, patient-centered, evidence-based medicine. And just to also let you know, I have clients that are, I said, that are big academic medical centers and hospital systems, but also physicians that are setting this up. And everyone seems to think, well, the big guys know what they're doing. They have it all figured out. I do think they have plans, and I do think they're starting to execute on them, but I don't necessarily think everyone has it all figured out. And anyone who tells me that, I would not quite believe. I think we're right now in an era of innovation, and I think maybe copycat approaches are not always the best, in that you might come up with something that could save money and provide better care to patients that maybe is not on someone's radar screen. I think looking at what data you can provide and looking at areas for this particular population, the Medicare population, and seeing how you can quantify the savings you can provide and the good quality. Right now, I think the next big push will be on patient population management, and I think the next big push within that will be chronic illnesses and multiple layered chronic illnesses on top of each other. And I think diabetes is the perfect example. But also, having come out of the hospital world, one of the things I saw was with the Medicare population, especially the younger Medicare population, with this idea of wanting the best and wanting to stay active and being involved in sports. And so one of the things I think the hospital struggled with was this idea, for example, of everyone wanting the absolute best hip you could ever have, so I could run a marathon in that hip, even if I hadn't even run a marathon ever in my life. So this idea of looking at that mentality and knowing that we've got an active population and where you can fit in and really provide good, valuable services. So another way you can get involved is being investors. So, and that could mean either having seats on the board and maybe sitting on some committees, but maybe not having full control of where the ACO is going. And then you might not, depending on different physicians I've talked to, some don't want to have the hassle of extra committee meetings and extra board meetings, and others want to be completely involved and really want to be driving the ship. So another way to do this would be actually to approach as on a contract basis. We'll talk a little bit about freedom of choice and how that can hurt some of the ability to be exclusive, but these are sort of some of the models and some of the things to think about when looking at this. And so now we're just going to walk through sort of how this works. So there is an application, and it has to be approved. And what I would say is the first applications that went in were getting approved pretty easily. And I helped a few ACOs that put in applications that I didn't think were complete and weren't forward-thinking. In other words, do you want to just do this for 3 years, or do we really think this is a transformation of where we're going in healthcare? And if you really want to transform healthcare, you can't just put a shell company up and not putting capital into it, and then say, okay, well, when we get our shared savings, we'll just pass it off by the percentages we put in our governing documents. The ACOs I'm working with now are really thinking about maybe moving into different models and the like. So just getting something up and running for an application date, I don't think is a good idea, especially now that some of the ACOs that I didn't think that they put a good enough model together were getting questions back from CMS before they got accepted and actually had to think through the issues. And I don't know whether they're going to be more and more stringent. There was a lot of political pressure around the election to get as many ACOs up and running and being able to put a press announcement out about that. But we also do want this to be successful. And anyone I work with, I say, why would you set up a joint venture that didn't have any capital in it? I had one client that said, well, we don't need to put any capital in it because we're just going to get the savings out of it. And I said, well, you at least have to have paper to print notices and do other things, so at least you have to put $100 in there, if not more. But ACOs are even moving towards the idea of even having employees and becoming real entities that operate on their own within a structure or within a joint venture structure. Some of the first ACOs had longer terms for their first year, but moving forward now, they will be on a January 1st start date. We don't have the date for the application this year, but they were due in September last year, right after Labor Day, and I assume they'll be sometime and then. You do have to put a notice in earlier in the summer just so that you get your ID to be able to upload all your application materials. And just to show how evolving CMS is in this process, this is what the 2013 application looked like. I will tell you that the 2012 application did not look this organized and did not have this nice logo on it. So we can see that CMS is really evolving along with this program. So some lessons learned from CMS that I actually agree with in this, and I just put these here. You ear dog this slide or circle it because we're going to go through some of this. But I think one of the things that's most important is to have your ACO participation agreements and all your agreements in place and all your documents in place and your structure in place before you apply. First of all, that's a legal requirement that a lot of people got away with not doing in the past. But also, you have a January 1st start date where you're up and running, and you want to know your structure before then because you will be able to get some claims data before this date, and you want to start actually slicing and dicing and getting organized, and maybe even having board meetings and operating between the time that you get approved, which will usually be in the fall, and the time that your start date is. Really look at the legal structure of how the governing body is going to work. And I have some tricks of the trade that we'll talk about in a moment to get around some of that, since depending on how you're set up, you may or may not have as big of a seat at the table. There will need to be a beneficiary that's on the governing body that can't be an ACO participant. So you can't take the CEO of one of the physician groups or the hospital and say, oh, that's our ACO beneficiary because they're over the age of and so therefore they're enrolled in Medicare. That's not acceptable. And we've had to structure things to worry about, well, at some point, do you want that beneficiary to actually have veto power over your whole structure? And so there's some ways to think through those issues. I think addressing remedial actions is important. And then I'd like to skip down to the highlighted one, which is there's a question in this application that talks about whether or not you're going to go to the private payers. And if you check yes, then you're going before the FTC and DOJ to share information about whether or not you have antitrust violations. So if we think back to the 90s, one of the big issues was the start of some of the big antitrust health law cases against people that were price sharing. In fact, when I was in New York, I actually was a managed care attorney when I was there, and there were issues where two hospitals that basically had the complete market share started sharing prices, and they lost that case. And I think that's a big worry about this. But at the same time, I have a lot of clients that their whole goal is to go from this ACO Medicare model into ACO commercial models. In other words, reaching out to the commercial payers to get quality incentives and payments, maybe even going capitated or taking on some risk. And so that's where I really think that a lot of people are headed, and that's their strategic plan. Integrated healthcare systems that took down their health plans are now putting them back up to help do population management and to house those people that are nurse practitioners and others that are doing some of the calls and reminders. So I think a lot of my clients have decided not to check this box on the application, but are moving towards this, and we'll have to think through the antitrust issues. The agreement is one where you will have no opportunity at all to negotiate. I've done thousands of contracts in my career, and this is the one where you will not be able to change anything. What's important to know is that the eligibility requirements and how the share savings is calculated, and the beneficiary rate of $5,000 will not change once you walk into that agreement. But everything else about this program can change, including quality. And they're actually looking now to add readmissions into the quality, and we'll talk about quality in a moment. And that if things change, then supplemental applications will have to be submitted by the ACO. The good news was they were going to have a 25% withholding, but now you don't have to actually go at risk at all, at least in these first 3 years. I predict that later you will have to go at risk, at least partially. And because of that, it's going to be quite interesting. You get your fee-for-service payment up front. Separate and apart from the ACO. That payment does not go to the ACO. What goes to the ACO is the shared savings or potentially the shared losses. So without a withholding, it means that in the future, it will mean requiring money to be paid back to the ACO. Right now, we're not going to be in that situation. And so that gave a lot of people the green light to go ahead and start doing these because they knew that they could take these 3 years and get really good at it, and they knew that, and then not have to worry about the withholding. I think we mentioned that I'm on the American Health Lawyers Association. I lead their credentialing, ACO credentialing committee. I do a lot of ACO work. I think one of the things that is not being focused on right now is the idea of credentialing in ACOs. And this can happen at the physician practice level too. It's this idea of, you know, if you decide to get, let's say, 3 groups of physicians together and they're going to form an ACO, and you're very excited about that, but then one physician in one of the groups is just not pulling their weight, they have horrible quality, they waste money, they're difficult to deal with, what are you going to do about that? You've let that whole group in. How about even worst case scenario? And I have a client that is an up and running ACO where they found out that one of the physicians in this 65 practice ACO might lose their license. And that might lead to an exclusion, and it might lead to other things down the road. And that person's NPI number is attached to this ACO. So having some kind of mechanism to screen on the way in and during, I think will be important. I think it leads also to this conversation of what's quality and what's peer review. There's so much quality activity going on that I think is quite wonderful. But at some point, when you start talking about individual doctors, and that ends up in minutes, or ends up outside of a privileged discussion, you're opening up yourself to potentially having malpractice plaintiff attorneys use that against you. There's some really good state immunity protections around setting up committees, and other states don't have those. There's obviously some federal protections. You can go that route. They may come with, you know, some more obligations. So I think this is something that's evolving. I'm actually drafting a letter to the data bank right now to see if they'll give an opinion about HICWA immunities and whether that an ACO could actually elect to do that. Legal entities, you can pick any kind of legal entity you want as long as it's a state legal entity. All the ACOs I've ever worked on or seen are limited liability companies. They don't need to be, but they've been for-profit limited liability companies. So you need to have a TIN. Again, that's just the important thing about the TIN is not how to get one, because that's very easy, but it's the idea that they're trying to track who's in what program. So there's other shared savings programs, and if you're in 2 shared savings programs, the government's not going to know which one's actually working if you're doing well. So the TIN actually tracks that. Now, that being said, I've set up new companies with new TINs, which is completely legal and has been able to work across big national systems with different companies to make this work. You also can use an existing system, and I've actually counseled people to think that through. You could use an existing entity, but a lot of times maybe the governance of the politics or the emotional ties to certain past issues are going to get bogged down if you use an existing entity. Whereas if you have a new entity, there's a fresh start, and I've seen that most people or all of them have used a new entity. Governance is quite interesting. So the governing body has to promote evidence-based medicine and patient engagement. So the emphasis is at the governing body level being engaged into these areas. And they need to be a separate identifiable body. So you can't just, a lot of times in governance when you set up a new entity, you say, oh, well, I have my board, and then we just kind of forget that we're actually a new company and we'll just keep the board meeting going. That would be a violation of this law. They really want this governing body to focus on the ACO and the patients that are in this ACO. I've listed here on slide 18 the characteristics of a governing body, and none of these should be surprising. Having oversight, transparency, fiduciary duty. They added a conflict of interest policy, and there needs to be certain composition and control of that governing body. What's interesting and different about the ACO world is that 75% of the governing body needs to be ACO participants. And I gave you that list on the previous slide. So physicians in a group, hospital employing physicians, hospitals and physicians joint venturing or partnering, or federally qualified health centers and the like. And so what they were worried about is that investment companies or health plans might want to get involved in ACOs, and they really wanted this to be physician or practitioner-led. So I've seen these numbers work, and they also have to be enrolled in Medicare. So I had one that wasn't enrolled in Medicare yet, and we had to kind of work through that. Some of the ways to work through this also is having supermajority powers, or basically having to vote more than over 50% or have on certain issues to deal with some of the 75% control issue. But I think this is actually different because normally you would have your investment interest match your ownership interest. But here you can have ownership interest and not really have invested any capital into it. A lot of that has to do with the fact that they waived the fraud and abuse laws for this program, and so there's different rules in the ACO world than there will be in the commercial market. So, for example, sometimes I counsel clients, go do the Medicare ACO. That way, you can get capital from other hospitals or other folks, and as long as it's reasonably related to the ACO functions, they can help you set the ACO up. But later, if you were to do the inverse and have be in the commercial market that you start, and you wanted to set up the company, you wouldn't be able to do it in that way. So although I have clients that are starting in the commercial world, if you really want to get fully integrated and think about this, starting with this ACO, Medicare ACO makes sense. What's also interesting about this is that they've actually have 3 required positions: a manager, compliance officer, and a medical director. That shows that it's supposed to be physician-led. And if you look at the 4th bullet point of manager, it says demonstrate the ability to influence or direct clinical practice to improve efficiency, processes, and outcomes. I think that that is an ideal CEO quality or executive manager quality. It's not how we've always thought about it in the past, but I think it is how we would want to think about it in the future. Part of the flexibility that was allowed was this idea that you could come up with some alternative management or governance structures. I don't know anyone who's put anything else forward, but this is a place where you could be innovative and come up with a different way to do this. Assignment of beneficiaries is actually going to be exceedingly important. One of the reasons why primary care physicians are getting gobbled up either as employees or into ACOs is because they drive the number of ACOs that go into or account into the ACO. The primary care physicians actually can only be in one ACO. Specialists can be in as many as they want. And that's where the advantage lies. So the primary care physicians have the advantage because people want them for their beneficiaries, and potentially the more beneficiaries you have, the more money you can make because you can leverage shared savings across a bigger population. But specialists have an advantage because they can be in multiple ACOs and have multiple arrangements. So I think that's really an important benefit. I'm not going to get too much into the methodology of assignment, but I would say it's primary care driven. But also what's going to be interesting here is the idea that not everyone goes to their primary care doctor every year, and also you might go to more than one primary care doctor. So how do you figure out who's in and who's out? If you're in a market where there's only one ACO, then you don't even have to worry about it, because as long as they're assigned to that primary care doctor, you're in. But if they're going to different primary care doctors, then there's a little bit of a formula to figure that out. There's also a two-track system. What's interesting, and I think I alluded to this before, is this idea of having no downside risk and then having some downside risk. So the two tracks are the one-sided model for 3 years, or the one-sided model and then moving to a two-sided model over the 3 years. You get a little bit more money if you go into the downside model and have some downstream risk. But I don't know any that are actually using the two-sided model right now. I do think we will evolve to that model. So let's get into the quality. A quality committee is actually not required. It was a requirement in the proposed rule. Everyone I've set them up, I've set up with quality committees. I like to do it on a two-tier level. I like to do it at the board level, so a high level, not even just one quality committee, but maybe more than multiple quality committees. And then have what I call operational quality committees. And this is a great place to get involved, even if you don't have ownership or if you do have ownership. I think a nice way to set it up is to have each practice area actually write their protocols and be accountable for protocols within an operational quality committee, and have those then get approved up through the board quality committee. And not all ACOs are set up that way, but if you want to come to the table with that idea, it's a great way to prove that you can get involved and work on an issue. I think the important thing here is that if you don't do your quality reporting right, there's actually possible sanctions and termination, and that the more quality, the higher quality, the more money you're going to make. The final rule ended up having 33 measures and 4 domains. To let you understand a little bit about what these measures look like, they're all physician practice measures. They started with those because they thought they would be the easiest for physicians to get involved in. There's patient satisfaction, questions such as, did you feel like you got to see a specialist on time? There's one that you could really work on. Did I have to wait in the waiting room too long? Another patient satisfaction caregiver. Some of it has to do with, did you get your flu shot? So and the like. So there's a lot under like preventative health. So these are, again, are physician quality measures. We're moving away from, I think they're going to move into readmissions, and these I will predict are going to change, but that patient satisfaction part will not. So you'll see on slide 27 the evolution from pay for reporting the first year, so just the idea that you get used to reporting, into a mix of pay for performing and pay for reporting. So some of the measures will actually, you'll have to hit the quality measures, and others you'll just have to report. By the end of the 3rd year, you've got to be able to do all of that, except there's some survey result module that they're having problems with, and maybe that will change. So the idea is we have so many places we have to report and so many ways we have to report. They're really trying to work through standardizing that, and hopefully that will work. So the better quality scores you obtain, the more money you make. So it's very important. You also have to save money. So if you don't save any money and you're good quality, then you're not going to get any money either. So the big question, do you have to have an electronic health record to have an ACO? I know I've talked to people that are very advanced in this process. They're not actually, one of them I know is not going to form, CEO is not going to form an ACO, but they're already aggressively pushing capitation on the commercial market. And what he would argue is not only do you have to have an ACO, but you have to have the same, you have to have electronic health record to be coordinated, but you actually have to have the same electronic health record. I've dealt a lot with people setting up health information exchanges to work on that issue, having the big pockets pay for connectivity issues, but there's actually the development of software that can target down into populations. And even the most advanced systems now, you have to do a lot of data crunching on the side, and I think that's a big frustration. But I would argue that although the rule is saying it's a doubly counted measure to report on for the ACO, and it's strongly encouraged by CMS, you actually don't have to. You can be in the paper world. But I think it's going to be very difficult, especially since CMS is not going to give you real-time data. They can't. They have claims data. Claims data by virtue of having to bill and then them to crunch numbers. You'll never get it in real time. So if you want any real-time point-of-care data, it's going to have to come from the ACO, or even if you're not an ACO, it's going to have to come from that electronic health record that's proprietary. The meaningful use standard, by the way, is in phase 2. I think the phases are going to get a little bit more drawn out. It's sort of a policy debate. Do you push people forward and require higher standards to get incentive payments, or do you allow more people to adopt electronic health records? I think they're balancing it. The ultimate goal, of course, is for patients to have a patient portal that can get in not only the reporting and exchange of information, but the ability for patients to have access to their electronic health records. The Secretary of HHS said that she felt in 2011, at least, that this was one of the most transformative issues in the delivery of health care, was electronic health records. You'll probably noted that the new HIPAA rules came out. They're effective. They're effective in a couple of weeks. The compliance date is 6 months from then, which is September 23rd. So along with all this and the meaningful use comes this idea that we need to keep it private and secure, and you'll see that in the quote. So data sharing, I think, is probably one of the most important qualities of ACO. And there's going to be 3 types. There's going to be data that you're going to get from CMS, which is great, financial data and maybe some quality data. And then you can elect to get some de-identified data, but the beneficiaries can actually elect out of the identifiable data. They can say, I don't want my ACO members to know about this very specific level of data. There's also data sharing amongst the ACO participants, and that will have some HIPAA obligations and requirements to think through. So we talked a little bit about quality reporting, and part of that will be reporting claims data, each individual group as claims data. There'll be survey instruments, and then right now the quality measures are on the group practice reporting option data collection tool, which is a physician tool. The data from CMS would be the beneficiary identifiable data, and I said the beneficiaries can opt out of getting it. CMS said, well, we could actually have decided to say that you didn't get it unless the beneficiary signed something, but that was going to be too much paperwork. So you have to give them a meaningful opportunity to opt out, and that can happen along with a notification that I'll talk about in a moment. But what's important here is you might not get the data that you think you've elected to, but I do think that data sharing and slicing and dicing data will be very important. Some of the quality concerns are the major costs of electronic health records. And that maybe these costs will mean that you need a physician, physicians might have to look to hospitals to get that infrastructure. Again, I know physicians that have set up this infrastructure without a hospital. And we can look to the fraud and abuse waivers for some of the help with the cost. Freedom of choice, though, I think what's bad about that is that, you know, Obama promised that this was not going to be managed care and that beneficiaries could go anywhere. But what it means is that you might try to steer somebody to a particular person or physician or specialist within the ACO, and they don't have to go there, and you can't do anything about that, except to try to influence that you think that they have better care. But at the end of the day, they have freedom of choice. Compliance is going to be a big issue because the federal government is worried that you'd set one of these up just for fraudulent purposes. So there will need to be a compliance officer and a compliance plan. Mandatory compliance plans are probably coming. We're waiting for the regs out. There's Affordable Care Act provision that said it will be tied to Medicare and Medicaid enrollment at some point. So I don't think compliance plans will be anything new for most people soon. They are looking at marketing. The big issue here is they're afraid that people, especially elderly beneficiaries, will not understand what an ACO is, and that you'll be able to influence them to think that it's maybe managed care, and they have to go a certain place. So there will be a requirement to file marketing with CMS, and then it's a file on use, so if they don't get back to you, you can use it until they tell you not to. Here's some look at what is considered marketing on slide 38, and as you can see, they added social media, this idea that we use Facebook and other things to advertise ourselves. They do not want the marketing to be discriminatory or other things, but you'll see that you still can do educational information, like remind everyone based on a population to go get their flu shot, and that's not considered marketing. And also written referrals to go see a specialist is not marketing. So eventually, we hope that CMS will come up with some template language for marketing, and that would be helpful. There also is this idea of the beneficiary inducement rules I just want to touch on for a moment. This idea that can you incentivize your beneficiaries or your patients to actually do something, such as go to a doctor's appointment? Can you give them a gift card? And there's a lot of rules around that. And there's different rules in the ACO world, which actually look a little bit tighter than the rules that you could do outside of an ACO. But this is some area where people have tried to get creative, but do realize that there's a lot of legal restraints around it. There will need to be notifications, and that happens at the primary care beneficiary appointment. And if not, then a letter goes out. What's interesting is that there's a requirement to post signs. And you would think, well, if you're notifying the beneficiaries, why do I need to post signs all over my office or all over the hospital? The reason for that is, and it says this in the commentary, is that the government wants everyone, not even just beneficiaries, to learn about ACOs and how we're transforming healthcare. So I think that's one of the reasons why they want the signs posted. To let you get a flavor of what else is happening out there besides ACOs, the CMS Innovation Center was also created by the Affordable Care Act, and it was set up to test payment and service delivery models with the same goals of reducing costs and increasing quality. And I listed here the three aims: better care for individuals, better care for populations, and lower growth of expenditures. These are the goals not only of the CMS Innovation Center, but the Affordable Care Act and ACOs as well. And so that's why you're going to start seeing, I think, a big increase on looking at population. They were funded with $10 billion. Their funding, I think, survived all these cuts. We'll see what happens, but they're funded through fiscal year 2019. Just to give you a flavor of what's happening, we talked about Pioneer and advanced payments, but this bundled payment initiative is out there. And they had 4 models that looked at different care settings, and what they were taking was a diagnosis and then having a diagnosis go across providers or care settings. So for example, one of the models was hospitals and physicians, and that whole care from the beginning of entering in the hospital until you were discharged was considered one episode of care for a particular diagnosis, and there would be a payment for that. There were 2 ways that would happen. One, it would get paid fee for service, but everyone just needed to work together. And the other one that was interesting, and I think that there'll be more models about this, is everyone getting paid up front and then having to gain share or split that cost. There were also other care settings, including hospital through to outpatient, and then some purely outpatient. The models that they've proposed that they haven't done yet are around chronic illnesses. So keep your eye out for those, and you can be in a bundled payment initiative and an ACO at the same time. They also looked at comprehensive primary care, which was health plans and primary care physicians working together, and I've seen an increase in health plans also acquiring primary care practices like they did in the 90s. The Healthcare Innovation Challenge looked at giving grant money for things that you don't normally get reimbursed for. So care coordination people, such as nurse practitioners, IT people, and maybe getting paid to do assessments that normally wouldn't have happened, to work on readmission and other issues such as depression and multiple chronic illnesses. The Independence at Home demonstration looked at aging in place, and the idea that transportation and other items were not reimbursable by Medicare, but would be necessary to age in place and might actually benefit beneficiaries. And at this point, I'll open up to questions, but just to leave you with, we are definitely in a changing world, and I see now that we know that this law is moving forward. I've seen a real aggressive uptick in ACO formation, thinking about readmission issues, signing up for CMS Innovation Program, or at least trying to figure out where to go next. And I think this is a great opportunity for you all to get a seat at the table, because people are really willing to listen right now and really look at options. And so I really think this is a very exciting time, and we're really looking for innovators and people to push medicine and healthcare forward. And we'll now turn it over to take some, for us to all take some questions.
Thanks, Sarah. This is Lloyd again. I want to thank Melvin and Sarah, and also Scott and the other APMA staff for organizing this. We have a number of questions that I'll try to get through with some editing on my part to make them efficient. If an individual is being told that he or she is not cost effective because he or she is doing more than is recommended, and there's a concern about malpractice issues as a result of this kind of direction, is there any sense that there'll be tort reform to protect providers in this situation?
So I'll give you, I mean, this is such an interesting thing. So I was on a panel with one of the CMS Innovation people, and someone asked us, we were on this big panel and we're talking through these issues, and somebody asked about tort reform, and and the CMS Innovation representative said, I don't see how that has anything to do with what we're talking about right now. And I looked at him and I took the microphone and said, well, I see how it has a lot to do with this, because I'll just use the example of the emergency room doctor. Someone comes into the emergency room, and that one time they don't do the MRI or the right diagnostic test or run them through them, and they miss something, then they are worried about a malpractice lawsuit. So I think there is going to be this balance between what is considered quote-unquote waste and what is considered good clinical protocols. And so to the extent I think that you are more involved, you have more of an ability to have a direction about that. But I don't know whether or not it will ultimately influence tort reform, but I do see those issues very linked.
Another quick question. We've heard the term diabetes as an entree into this system, but what if you have a practice that has little or no diabetes and you have no personal interest in generating that kind of practice? Is another way a practice could demonstrate its efficiency and enter the ACO model effectively?
I mean, I think sports, I'll just use sports as an example, might be another way. So for example, I work at Holy Cross Hospital, and they set up an emergency room that was purposely focused towards that population, and it was wildly successful.
Which is what you're saying.
Yeah, I mean, they had an emergency room that was dedicated just to elderly population, the Medicare population. And just by putting... Sarah, I'm going to keep going, because I think you just answered the question. If an individual is questioning whether he or she is cost effective, how would you determine that if you're not part of an ACO now and no one's telling you if you are or not? If you could look at your Medicare claims data or your claims data by payer mix, but it is very difficult. I was just having a meeting with people that they're about to set up an ACO, and getting data is exceedingly difficult. And they can look at, some integrated health systems have health plans for their employees, and what they're doing is they're looking at that data to try to extrapolate like what might be happening in their general community. But it is very difficult. But to the extent that you can look at your claims data, I think that's important.
Yeah, the state of Massachusetts is now sending us, reports on our efficiency, and it does give us some measure, but it's not drilled down to the level that really can evaluate our practice. I'm afraid there's a bunch of other questions, and I'm sure there are a lot of other questions that people haven't sent in, but we are out of time. And once again, I want to thank everybody for their attention. This talk has been recorded, so if you want to go back to it, it's online at APMA. Thanks, everybody. Thanks for your participation tonight.
Okay, thank you.